Thanks very much, Anna. That was a fascinating talk about assess meso. So as you might have just heard Anna at the end saying, we are now moving on to our Q&A session for this final session of the day, which was the research showcase. Again, you can put your questions in the Q&A. We've got a couple that have come in already. I think the first one from Mavis Nye, I can actually probably ask to both of you, but clearly from different perspectives, one being the mouse perspective and one being in humans. So Mavis has got a fantastic story in that she is now 13 years on from diagnosis and still surviving. 7 years with immunotherapy, which we aren't really seeing in the trials that you've seen so far. Are there studies being carried out on survivors like Mavis Nye to see, for example, in their genetics or something else that makes them do so well, either in the mouse model, Daniel, or are we looking at it in humans, Anna? So I'll maybe get Daniel to go first.
I think, Mavis, thank you so much for the question, and I know you from a few of these infrequent encounters. I think the challenge that we have, Mavis, is that there aren't enough people like you, to draw firm conclusions. It would be, I don't know what would be involved, but if it would be at all possible to retrospectively get access to your early biopsies and see, to include those in our analysis, I think that would be powerful to maybe give us an indication as to how you've done so well compared to so many others. So and keep on rocking. It's great to see you on Twitter, and I'm a big fan.
Anna?
Yeah. I mean, I guess I would just add to that it just kind of highlights really how much we don't know about mesothelioma, and we recognise that there is quite a wide disparity in people's clinical courses, and we know that there is a group of people who survive for a really long time, and that's great. And you're right, Mavis. They're you're the people that we should be studying, because that's what we want to replicate. I think, and I hope, one of the opportunities that Assess Meso provides is this opportunity to really kind of drill down into the different phenotypes, as in the different groups of people with this disease, so we can understand more about, when we first see someone, when we first tell someone we've got mesothelioma, we can say, oh, it looks like you're in this group of people who behave in this way. And so, ideally then moving on to almost personalizing their treatment, much like we have in non-small cell lung cancer. You've got this biomarker, or you've got this, genetic mutation, so this is the treatment that will work best for you. Or, you've got this particular set of characteristics that means you're a Mavis and you're going to live for a long time anyway. So, enjoy it, and we won't give you any toxic medications until you really need them. So, I think that, real ability to differentiate the disease types, the phenotypes at point of presentation, is something that we really need to move to in mesothelioma.
And Daniel, are you seeing that in any of your mouse models? Obviously they have a much shorter lifespan after disease development, but are you seeing any differences in survival with your genetically engineered mouse model, and can you study those alterations?
We've started with the most genetically complex, and now we're working our way back slow, and it's taking a while, of course, to breed up those cohorts. But certainly, if you inject asbestos into a wild-type mouse, and this was work done from Marion McFarlane's group, we're experimentally allowed to keep the mice alive for about 18 months before age becomes an animal rights or an animal welfare issue. And so, what Marion found was only about 15% of mice where she injected asbestos, wild-type mice, succumbed to mesothelioma. Now, certainly the rest of them had pre-malignant disease, they had the inflammatory response, they had all of that early stage disease that was still there, but they hadn't gone full-blown mesothelioma. And so really what we're trying to do together is to fill in the gap between wild-type scenario and the genetically complex model that we started out with, and we are breeding those in. We've got cohorts running right now, and I think we are going to see that different combinations of mutations give greater acceleration compared to others, and I think that's absolutely, I think Mavis is right, that's absolutely going to shed light on why some patients survive better than others.
Yeah, I think it's really key for kind of future research, really. Another question, Anna, on blood biomarkers in mesothelioma or even pleural fluid biomarkers. Are there, obviously I know the ones that don't work, are there any out there that you think could work for diagnosis, that are certainly potentials, and any that might help us in predicting who might respond better to immunotherapy, for example?
Yeah, so I mean, I think there's been some interesting stuff coming out of the clinical trials on this, and the key one would be in PD-L1 in terms of particularly response to immunotherapy, and there were some signals in the Nivo-IPI trial that PD-L1 positivity does predict response to treatment, but there's difficulties. I mean, the biomarker trials are so challenging to do, as you know, Selena, because they're quite difficult to fund because they're not very glamorous. So they're almost always done as add-on analyses to clinical trials, and then you're automatically limited by the fact you've got a clinical trial population with the selection bias associated with that. So having something like diaphragm is very, it's very unique to have such a generic all-comers population, and I think again taking that representative population, that's what we're going to need to do to see who's got the right biomarkers, who's going to respond to what treatment. But yeah, to answer the question, I think PD-L1 is the most obvious one, but that in terms of response and to treatment. But I have to say, diagnostically, I'm a bit uncertain. But you might know more than I do. What do you think?
I think the proteomics side of things is interesting when you start looking down. Proteomics is a really interesting area in that you can look and measure thousands and thousands of proteins, and I think the difficulty then becomes what is an inflammatory signature, what is just a signature from the asbestos related inflammation versus a cancer signature, and I think probably looking into that in more detail will hopefully provide us with more targets that we can then assess in future studies from a biomarker perspective. We have a question, Daniel. Do you think that treatments that we're studying in the future, or hopefully near future, should be delivered intravenously or intrapleurally? And can you compare the difference in those treatments within your mouse models?
It's a great question. I think intrapleural delivery is potentially has real legs in mesothelioma, because it would avoid some of the systemic side effects of some of these therapeutics, and you'd be able to get locally very high concentrations if high concentrations are indeed the appropriate way to go. But certainly, to get local exposure to specific agents. I think that's a great way forward. It's a challenge in the mice. There's only so many times that we can inject into the pleural space, and really up until our mice are quite advanced in terms of their symptoms, we don't have an awful lot of space to work with. So the tricks that we use to minimize the injection so that we don't puncture all the way into the lung, or that the needle actually penetrates into the skin far enough to deliver its payload, we're not allowed to do that repeatedly. So intrapleural in the mouse models isn't going to be a routine route. Now, on the other hand, some of these things that we are testing, so PD-1 blockade, we have tested PD-1 blockade in one animal model where we know we've got almost no CD8 infiltration. PD-1 blockade did nothing, and indeed, if we look at PD-L1 expression, it's extremely rare in that one genetic cohort. In another genetic cohort, we're just gearing up right now to try PD-1 blockade, but we can already tell from the molecular signatures that there's loads of CD8 cells in there, and it turns out that that's a disease with sarcomatoid phenotype. So the mouse model again is recapitulating the human situation where the sarcomatoid phenotype is associated with high numbers of infiltrating CD8 cells that are potentially responsive to PD-1 blockade. The one other point I wanted to touch upon there is that looking at responses to chemotherapy, we see very different responses in animals that have P53 mutation. So if they're a P53 mutant animal, they really, really suffer from chemotherapy. Whereas if they're P53 wild type, they actually do a lot better. And I think that's should be guiding clinical decision making. If there's and P53 mutation isn't very frequent in human meso compared to some of the other cancer types. So with P53 mutation occurring in less than 20%, maybe those patients should not be getting hardcore chemotherapy. Certainly, from our mouse models, they really, really suffer, and we've had to take them.
Okay, thanks for that, Daniel. I've just got two more sort of quick questions, mainly to Anna. The first being, Isabel asks, should patients be informed if pleural plaques are identified incidentally prior to meso diagnosis or symptoms?
Well, I think this was sort of touched on earlier, wasn't it? And the problem is that we know that pleural plaques are an indicator of asbestos exposure. So I guess that's helpful to know if someone was unaware of their own exposure. If someone with a lower exposure, such as teachers, the groups we've been hearing about recently. So I guess it's helpful in terms of a marker of you have been exposed to asbestos, but we know they're not pre-malignant. They don't go on to develop into disease, and so not everyone with pleural plaques will get mesothelioma, and not everyone with mesothelioma will have started with pleural plaques. So there's big populations being missed if you focus solely on the pleural plaques. And it ties into my sort of other research interest, which is screening, which is if you're screening for anything, there has to be merit in picking up the disease early, i.e. a treatment that will stop it progressing or cure it or whatever. And unfortunately, although we're getting better, we don't have that right now in mesothelioma. So, finding someone with, my lights have just gone off because I sat still for too long. Having someone with pleural plaques and following them up until they do or do not develop mesothelioma, it probably isn't going to gain that person much, and it is going to give them a huge amount of anxiety having yearly scans or whatever it is, not to mention the radiation that comes with that. So I don't think, it's not our practice in the UK to follow people up with plaques, and I doubt it is up there in Scotland with you either, just because, the merit is unproven.
Yeah, so I agree. We don't routinely follow up pleural plaques, but we would always inform our patients if they do have evidence of pleural plaques picked up on either a chest X-ray or a CT scan, A, for their information, and B, also in Scotland, Carolyn McRae's just pointed out in the Q&A that damages can be claimed for pleural plaques as well as other asbestos-related conditions. So our general practice would be to inform anyone if they've got pleural plaques. But as you say, I think it's a very careful discussion to explain what they are, what they aren't, and that they don't necessarily need followed up. My final, just really quick question before we close, Anna, is how do we try and encourage expansion of trial eligibility criteria so that we can incorporate more real world populations?
Yeah, I mean, it's my sort of personal hobby horse, so I won't talk forever on it for the last question. But the thing is, there's no right or wrong. It makes complete sense from a drug company point of view, and it is normally the drug companies funding the phase 3 randomized trials. They have spent often decades bringing this drug from the lab to the clinical setting, and as we heard earlier, for someone like if that's been your life's work, to fail at the final hurdle is really quite devastating, and so the drug companies don't want that to happen. And so they want to test the drug in the people it's most likely to work in first. My personal feeling, as the person who hasn't developed the drug and is going to be giving the drug, is the opposite. I want to know if it's going to work to this person in front of me who isn't, doesn't fit that perfect textbook criteria. So it's a balance between these very strict, explanatory type trials and a more pragmatic approach, where the pragmatic nature of the trial is more replicative of real world data or real world experience. And so all of my research has an incredibly heavy pragmatic approach to it, because that's what I care about. But I haven't developed the drug, and I haven't spent all this time bringing it to market. So that's my own personal preference, and there is no right or wrong.
Sure. I think we've sadly run out of time for our Q&A, but thank you, Daniel, and thank you, Anna. I'd just like to essentially bring the day to a close. I think hopefully you've all taken away lots and lots. I certainly have. It's been great to see what has happened with the network over the last 2.5 to 3 years, and it's really exciting to see what's going to come in the future. I'd like to thank in particular our charity sponsors, so Macmillan, Meso UK and Action on Asbestos, and in particular I'd like to thank Digby Brown for sponsoring this day today. And I think we can all agree that we were all really touched and captivated by Graham Menzies' story, so I'd like to personally thank him as well for taking the time to contribute to today. I believe that all of our talks will be available via the Scottish Meso Network website in the coming weeks, so please look out for that. And then I would just like to thank you all for coming today virtually, and fingers crossed for the Scottish Health Awards that we've been nominated for, as Kevin mentioned, next week. So thanks very much, and I'll bring the day to a close.